Yeah, good morning to all the third year PharmD students. So this is Dr. Sunil Kumar. So in the last class, I was discussing about chemotherapy, and in that I was specifically discussing about sulfonamides. And we have seen the story of sulfonamide started when a scientist by name Domac, he invented a drug or a dye that is called as sulfonamidochrysoside or prontosil red. And that prontosil red or sulfonamidochrysoside, he used the drug to treat streptococcal infection in mice. Okay, and the drug was found to be very effective. And later, the same sulfonamidochrysoside or prontosil red he used to treat his daughter who is suffering from streptococcal septicemia. Okay, and it was found that so sulfonamide was very effective, and he cured his daughter with sulfonamide. So that is prontosil red. Okay, so now this entire story happened in 1930. But in 1937, as I mentioned in the last video, that it has been made very clear that prontosil red is not the actual product that has been found to effective on streptococcal septicemia or streptococcal infection or pyogenic pus producing infection. Okay, it was found that prontosil red is broken down into some other product, and that product is mainly responsible for effective action on streptococcal infections. Okay, and also pyogenic bacterial infections. So what is that product which is broken down from prontosil red? That is nothing but sulfanilamide. Sulfanilamide is a drug which is broken down from the parent drug that is called as prontosil red. Prontosil red here, it acts as a prodrug which will be metabolized into sulfanilamide, and sulfanilamide is found to be very effective in pyogenic infections as well as in the treatment of many streptococcal infections. So later and subsequently, there are many derivatives of sulfonilamides are introduced. What we are using right now, sulfonamides, which are the derivatives of sulfonilamides. But their utility is not, I mean to say that, widespread. So the current utility of these sulfonilamide derivatives or sulfonamides, they are limited. Okay, and this is because of two reasons. One, there is a rapid emergence of bacterial resistance. Bacteria which used to be inhibited or killed by sulfonamides, they have gained resistance towards this antimicrobial agent. Okay, so microorganisms has gained resistance towards sulfonamides or sulfonilamide derivatives, and microorganisms have become ineffective. Okay, or I can say that antibiotics have become ineffective on microorganisms. Okay, and another important reason is we have right now many effective and safer drugs than sulfonamides or sulfonilamides. Okay, hence the utilization of these sulfa drugs or sulfonilamide derivatives or sulfonamides have been currently their utility is limited. Okay, this was what we're discussing, and we also discussed about chemistry. They are the derivatives of I mean to say that sulfonilamide. All sulfonamides are derivatives of sulfonilamides, and we also discussed there is an amino group at the para position, and to the another end you have sulfonamido nitrogen. Okay, so I will share the screen. Let's continue. Yeah, I hope this is visible to everyone. Just a minute, let me zoom it a bit. Yeah. So here we can see, this is the chemistry. I think already we discussed all sulfonamides are derivatives of sulfonilamide, and sulfonilamide is it is obtained from prontosil red. Prontosil red is broken down into sulfonilamide. Okay, and sulfonilamide chemically you can call it as para-amino benzene sulfonamide. Para-amino benzene sulfonamide. This is the structure of sulfonilamide. Para-amino benzene sulfonamide. We discussed in the last video. So individual categories of drugs, they differ when there is a substitution at first nitrogen and fourth nitrogen. This is N1 and N4. If you do substitution, definitely there will be different drugs can be obtained by doing this substitution. Okay, so here individual members differ in nature. Okay, especially N1 substitution, that is sulfonamido nitrogen. I think I mentioned sulfonamido nitrogen. Okay, so here this N1 substitution, generally what happens when there is a substitution at N1 position in sulfanilamide? Definitely it will count solubility. Solubility will change, potency will be altered, and pharmacokinetic property will also alter. Okay, three things will change when there is a substitution at N1 for nitrogen in sulfanilamide. One, solubility will be altered, potency will be altered, and pharmacokinetic, that is ADME characters, will be altered. Okay, and if you go for substitution at N4 position, N4, or that is called para-nitrogen, para position, para amino position, or para-nitrogen, definitely antibacterial activity will be altered. Right, that is spectrum of activity will be altered. Means, so as the substitution keeps on increasing, or as the substituents are attached, the spectrum also changes. Okay, so some kind of groups, when they are attached, the spectrum may be narrow. When some groups are attached, the spectrum may be widened or broadened. More bacteria will be inhibited or killed by sulfonamides when there is a substitution at N4 position. Okay, so that is about a brief chemistry of sulfonilamides or sulfonamides. Okay, so now quickly enter into classification. Okay, here the classification what I have displayed, it is on the basis of duration of action. Okay, so means some drugs are short acting, some sulfonamides are intermediate acting, some are long acting, and some are used for special purposes. Let me discuss here. So let me classify short acting sulfonamides. Short acting sulfonamides. Let me once again repeat. Sulfonamides, what we are discussing, they are nothing but they are the derivatives of sulfanilamide. Please try to understand. Sulfonamides are the derivatives of sulfanilamides. Okay, let's classify. So short acting, you have drugs like sulfadiazine and sulfisoxazole. Sulfadiazine and sulfisoxazole, whose duration of action is around 4 to 8 hours. Okay, that is example sulfadiazine and sulfisoxazole. Intermediate acting, so quite longer. So their duration of action will be 8 to 12 hours. You have two drugs that belongs to this intermediate acting sulfonamides. One is sulfamethoxazole and another one is sulfamoxazole. Sulfamethoxazole and sulfamoxazole. So they belong to intermediate acting sulfonamides. That is sulfamethoxazole and sulfamoxazole. And long acting sulfonamides, that is nearly 7 days. You can see here, nearly 7 days. So like this is nearly 7 days, or approximately 7 days. Okay, so what are those long acting sulfonamides? Sulfadoxine and sulfamethoxypyrazine. Sulfadoxine and sulfamethoxypyrazine. Okay, so let me also tell you, earlier we used to write sulfa as SULPHA. This is the earlier way to write sulfa. But now you find sulfa will be written as SULFA. This is how to write sulfa right now. Okay, so that's why in few books you may found sulfa in this manner, SULPHA. But the current trend of writing sulfa is SULFA. Okay, so that is long acting, that is sulfadoxine and sulfamethoxypyrazine, whose duration of action will be around 7 days. And some special purpose sulfonamides are used here. Let me quote. That is called as sulfosamide sodium. Sulfosamide sodium. So this is mainly used in eye drops. Okay, eye infection. Sulfosamide sodium. Sulfasalazine. This is used especially in ulcerative colitis, where there is severe inflammation of your I mean to say that severe damage or severe infection or inflammation of your small and large intestine. Okay, so that is called ulcerative colitis, especially large intestine. Okay, and here further you can divide this ulcerative colitis into two types. I mean to say that this is especially ulcerative colitis is a part of inflammatory bowel disease. Please try to understand. Okay, IBD, we call it as IBD, inflammatory bowel disease, IBD. So this drug, sulfasalazine, it is used in IBD, inflammatory bowel disease. There is a severe inflammation due to infection of your bowel or intestine. And in that you have two problems. One is Crohn's disease. Further two categories. Okay, I think you have studied this. One is called as Crohn's disease. Crohn's. Okay, and another one is ulcerative colitis. Ulcerative colitis. One is Crohn's disease and another one is ulcerative colitis. Okay, so these are the two different types of IBD. Okay, so there is quite different. That is the nature of inflammation. Yeah, sorry for the interruption. There was some network issue. Okay, let me once again share the screen, what we are discussing. Yeah, coming back to our discussion, I told you sulfasalazine is a wonderful sulfonamide which is used especially in IBD, inflammatory bowel disease, where there is a severe infection or inflammation to your intestine. Okay, and Crohn's disease, the only one difference that I would like to quote here, because there are several differences, but up to your level, if anybody asks you what is the difference between Crohn's and ulcerative colitis, both are problems related to inflammatory bowel disease. And in Crohn's disease, there is a severe inflammation to both small and large intestine. Okay, there is a severe inflammation of small and large intestine. But in ulcerative colitis, only the severity of the inflammation is restricted to large intestine. Okay, so infection or inflammation, if it occurs in both small and large intestine, in many parts of small and large intestine, then it is called as Crohn's disease. Okay, and if inflammation is restricted only to large intestine, that becomes ulcerative colitis. Okay, so tiny ulcers will be formed all along the length of small and large intestine in Crohn's disease, and here ulceration can be seen only in large intestine in ulcerative colitis. So that is the use. Okay, and here you know that mefenide and silver sulfadiazine, they are mainly used in burns. Okay, so in burns they are used. Okay, so in many like how we are using Bernol. Okay, in the same manner, so mefenide and silver sulfadiazine, they are used in burns and many what can I say, pseudomonas related infection, which are very frequent in burns. Okay, and I think one of the brand name is also available. I think you have seen Silver X. Okay, I will write here. So Silver X ointment. If you go to a medical shop and if you ask Silver X, okay, definitely most of the I mean to say that medical shops will have this Silver X. But as you know that many non-pharmacy individuals are working in medical shops. That's why they will actually it is mentioned like this on the ointment, AGX. Okay, so but we know that AG is silver. Okay, that's why we spell it as Silver X. But if you go to a medical shop, if you ask Silver X, they might get confused. Okay, you have to say Ajax. They will use the word Ajax because they don't know. Okay, most of them they don't know AG as silver. Okay, so that's why. So this is Ajax or Silver X is a cream which contains silver sulfadiazine, which is mainly used in burns. Okay, so this is the classification of sulfonamides. Okay, short acting 4 to 8 hours, sulfadiazine, sulfasoxazole. Intermediate acting 8 to 12 hours, sulfamethoxazole and sulfamoxazole. Long acting nearly 7 days, sulfadoxin and sulfamethopyrazine. And special purpose sulfonamides, long acting up to 7 days, the duration of action, sulfadoxin and sulfamethopyrogen, and special purpose sulfonamides, sulfostamide sodium, which is used in eye infections, sulfasalazine, which is used in inflammatory bowel disease, and mefenide and silver sulfadigene, which are mainly used in burns related infections. Okay, now coming to antibacterial spectrum, let me also discuss this. See, so they are bacteriostatic. First of all, you have to understand sulfonamides are bacteriostatic, means they are not going to kill most of the bacteria. They are going to inhibit the growth and multiplication of gram positive and gram negative bacteria. Okay, they are bacteriostatic against many gram positive and gram negative bacteria. So what are the sensitive organisms? So just you remember, because it is not possible to remember all the organisms, just you try to remember. So many Streptomyces pyogenes, you see, this is the major utility. These are the microorganisms that are responsible for pus. Okay, Streptomyces pyogenes. Okay, it is highly effective. Influenza, H influenza, Haemophilus ducreyi, what is this? Calamatobacterium granulamatis, which is going to cause an eye infection that is called trachomatis. Okay, that is caused by this Calamatobacterium granulomatis. A cholera causing microorganism Vibrio cholerae, which is a spirochete, which is a spiral bacteria, and only few microorganisms of Staphylococcus aureus, gonococci, meningococci, they are sulfonamides are effective only on few species of Staphylococcus aureus, gonococci, and meningococci. But most of the sensitive organisms are this up to here. That is Streptomyces pyogenes, H influenza, Haemophilus ducreyi, Calamitobacterium granulomatis, and Vibrio cholerae. Okay, and even it is quite mild effective. Okay, few species of pneumococci, E. coli, and Shigella. Okay, they are effective. Means they are sensitive to that that particular sulfonamide. Okay, and majority are resistant. You can see here. Only few species of Staphylococcus aureus, gonococci, meningococci, pneumococci, E. coli, and Shigella are sensitive, but majority of the microorganisms are resistant. Okay, that's why in these infections, it's better to search for alternate option. Okay, and also chlamydia trachoma and lymphogranuloma venerum. Okay, that is called as that will cause what is that? LGV, lymphogranuloma venerum. Okay, which is responsible for sexually transmitted diseases. Okay, so that is also ineffective. These microorganisms remain ineffective. Okay, so just you remember them. Okay, so because when we cover many antibiotics, you come across several microorganisms. It is quite difficult to remember all the microorganisms. What I mean to say that you try to remember those microorganisms on which the antibiotic or antimicrobial agent is more effective. Okay, least effective, insensitive, you no need to remember. Okay, yeah. And coming to the most important aspect, mechanism of action. This is, you have to understand. See, let me begin this in this manner. First of all, sulfonamides are bacteriostatic, as I mentioned. They are going to inhibit the multiplication of bacteria. Okay, and here, as I mentioned, sulfonamides have bacteriostatic action and act by substrate competition. What is that substrate competition? Let me tell you. First of all, you should understand microorganisms require a particular chemical for their growth and multiplication. Okay, I will talk in this manner. Microorganisms require folic acid. Please try to understand. Folic acid for their growth and multiplication. Is it clear? Microorganisms require folic acid definitely for their synthesis of further DNA. Okay, for the replication, they require folic acid. And where do they get folic acid from? They get from para-aminobenzoic acid, PABA. They get from para-aminobenzoic acid. Okay, so let me differentiate here. In humans, we also require folic acid for the multiplication of our cells. But in human beings, folic acid, what we are getting, most of the folic acid we are getting, that is through diet. Okay, dietary folic acid is sufficient for our multiplication of our cells. But in bacteria doesn't have dietary folic acid. Bacteria will get folic acid only through PABA, only through PABA. Please try to understand. Okay, so bacteria has to synthesize PABA on its own, and from PABA it will get folic acid. Okay, we don't require any PABA directly from. I mean to say that from diet we can get direct folic acid through vegetables, through green leafy vegetables or meat, etc. We will get PABA. We will get direct folic acid. But here, PABA has to be synthesized by microbe or bacteria, and from PABA it will get folic acid. Okay, and without folic acid, bacteria cannot multiply. The bacterial DNA will not be synthesized. Okay, yeah. So now, here, let me make the mechanism very clear. Here, what is happening? Bacteria wants PABA for the synthesis of folic acid, which is very essential for its growth and multiplication. Now, if you observe the structure here, please pay attention, my students. So here you can see the structure of PABA, and you can see the structure of sulfonamide. You can see. Okay. So let me use another pointer here, just a minute. So you can see here, there is a structural similarity between PABA and folic acid. You can see here. So up to this portion, it is almost similar. Do you agree? You can see here. This is PABA and this is sulfonamide. Okay. Up to this portion, so both are similar. There is a structural similarity. But here you have COOH group and here you have SO2NH2 group. Due to this structural similarity, when you take sulfonamide, what happens here is bacteria fails to differentiate. Bacteria fails to differentiate between PABA and sulfonamide, and it will take up sulfonamide instead of PABA. Please try to understand. Bacteria gets confused and it will pick sulfonamide instead of PABA. And as I told you, both PABA and sulfonamide may have certain structural similarity, which makes the bacteria to get confused, and instead of PABA, it picks sulfonamide. But there is a difference. As I told you, there is a difference. Here you have COOH group and here you have SO2NH2 group. Okay, that is sulfonamidobenzene. This is sulfonamidobenzene. Sulfonamido group is there. Okay, and due to that, folic acid will not be synthesized when bacteria picks up sulfonamide instead of PABA. It forms an altered folate. It forms some altered folate, some different type of compound, which is bacteriostatic, which will further inhibits the multiplication of bacteria. If if a bacteria picks PABA and if it utilizes PABA, then it produces folic acid. Okay, is it clear? But instead of PABA, due to structural similarity, it will pick sulfonamide. It takes sulfonamide. Okay, and when it takes sulfonamide, it won't be converted into folic acid. So that folic acid will be converted into some altered folate, and that altered folate is metabolically injurious. It can't involve in multiplication. Instead, it will block the multiplication. That's why there is a bacteriostasis. Okay, this is the mechanism of action of sulfonamides. Okay, and even if you go in detail, what is happening here? See, please try to understand. Please try to observe this pathway. Okay, so here what happens? How PABA is converted into folic acid? That is very important. First, what happens here? You can see PABA is converted into DHFA. That is, DHFA is nothing but dihydrofolic acid. But dihydrofolic acid is not sufficient for a microorganism to carry out DNA synthesis. Okay, so for the dihydrofolic acid has to be converted into tetrahydrofolic acid. Okay, so this tetrahydrofolic acid is very, very essential for the replication of the bacteria. You can see here, if you observe carefully, further I have shown from tetrahydrofolic acid, purines will be synthesized and finally DNA will be synthesized. Okay. If your bacteria synthesizes a new DNA, definitely it will multiply. But here you can see this conversion, PABA to dihydrofolic acid to tetrahydrofolic acid, then purines and DNA. So it involves an enzyme that is called folate synthetase. It is called as folate synthetase, or there is another name here you can see, dihydroteroate synthetase. Okay, I will write here. It is also called as dihydro. I will continue from here. Teroate, T-E-T-E-R-O-A-T-E, dihydroteroate synthetase. This is called N-T-H-A-S-E, dihydroteroate synthetase. So here, PABA is converted into dihydrofolic acid into dihydrofolic acid into tetrahydrofolic acid, and tetrahydrofolic acid further converts into purines and DNA will be synthesized. That will facilitate multiplication of bacteria. But here what happens, PABA will have two options. Sorry, folate synthetase will have two options. One, it can bind with PABA or it can bind with sulfonamide. That's why I use the word there is a substrate competition. Why I use this word substrate competition? Because here what is the substrate? Substrate is folate synthetase. Substrate is folate synthetase. Folate synthetase will have, there is a competition between sulfonamide and PABA to bind with the folate synthetase. But in this competition, based on the affinity towards folate synthetase, so the sulfonamides will have more affinity towards folate synthetase when compared to PABA. That's why sulfonamide binds with folate synthetase instead of PABA. If PABA binds with folate synthetase, then there is a formation of tetrahydrofolic acid, and further purines and DNA, there is a multiplication of the bacteria. But instead of binding with PABA, folate synthetase binds with sulfonamides and it will form an AF. What is AF? Altered folate. And this altered folate is not tetrahydrofolic acid. It is not helpful in the synthesis of purines and DNA. Instead, it will block the synthesis of purines and DNA. Okay, in simple language, I can say that sulfonamides will bind with folate synthetase and it will block the formation of tetrahydrofolic acid. That's it. That is the bottom line. Okay, sulfonamide inhibits folate synthetase by binding with it, and they will block the formation of tetrahydrofolic acid. Thereby, there is no synthesis of DNA. There is no multiplication of the bacteria. That will result in bacteriostasis. Okay, that's it. So that is the mechanism of action of sulfonamides, and this was identified by two scientists, Woods and Fildes. Woods and Fildes, 1940. That is Woods and Fildes hypothesis in 1940. All right. If anybody asks you, explain the Woods and Fildes hypothesis 1940 with respect to sulfonamides, then it is nothing but the mechanism of action. The mechanism of action or inhibition of folate synthetase by sulfonamides. Okay. So instead of PABA, so folate synthetase will be attracted towards sulfonamides and it will take up sulfonamides, and sulfonamides will inhibit folate synthetase. There will be no formation of tetrahydrofolic acid, and that is nothing but that will result in bacteriostasis. Okay, so that is the mechanism of action of sulfonamides. And there is another mechanism you can also write in this, even you can include this. It has been seen that generally PABA will combine with the terene residue. Please try to understand. PABA combines with terene residue and it will form dihydroteroic acid. It will form dihydroteroic acid, and further dihydroteroic acid combines with glutamic acid and there is a formation of dihydrofolic acid. Okay, further there is a formation of tetrahydrofolic acid. Okay, these two should be combined, PABA and pteridine residue. PABA and pteridine residue of what? Pteridine residue of folate synthetase. This enzyme will have some structure that is pteridine residue. Okay, pteridine residue of PABA has to, pteridine residue of folate synthetase has to combine with PABA, and there will be a formation of dihydroteroic acid, then glutamic acid will combine, there is a formation of dihydrofolic acid. So sulfonamides will block this combination, inhibits the combination of PABA and pteridine residue. Okay, so because PABA will not be allowed to bind with folate synthetase. Instead of PABA, sulfonamides will bind, and this combination will be blocked or inhibited. And finally, there is no formation of dihydroteroic acid, no formation of dihydrofolic acid. That's it. Okay, so that is about mechanism of action of sulfonamides. I hope I made it very, very clear. Okay, and here the question arises, as I told you earlier, the answer I mentioned, sir, folic acid is also required for human beings. Even in pregnancy, folic acid tablets will be given. Even in malnutrition, folic acid tablets will be given. Even in anemia, folic acid, megaloblastic anemia, folic acid tablets will be given. Does sulfonamides at overdoses, are they going to cause any damage, or at therapeutic doses? Let me talk about therapeutic doses. At therapeutic doses, are they going to cause any damage to our folic acid production? I say no. Why I'm saying no here? Because for bacteria to synthesize folic acid, it requires PABA. Okay, so it requires PABA. PABA has to combine with folate synthetase, and there is a production of DHFA, then there is a production of THFA, tetrahydrofolic acid. Okay, but this tetrahydrofolic acid we are not getting from PABA. We are directly getting tetrahydrofolic acid through diet. Please try to understand. That's why there is no question of folate synthetase inhibition. Okay, directly the major source of folic acid, that is THFA, directly we are getting through diet. That's why we don't worry about PABA. Okay, even if some amount of PABA is inhibited, we don't worry. We are getting more amount of folic acid through THFA. Okay, directly we are getting main source of folic acid through diet. That's why if PABA is inhibited in our cells in small amount, that is not a big problem, because large amount of THFA we are getting through diet. That's why human or mammalian cells does not remain unaffected with sulfonamides. They remain unaffected with sulfonamides. Okay, so that's it. Okay, and how microorganisms will gain resistance to these sulfa drugs or sulfonamides. Okay, you please note down what are the resistance microorganisms. Already I have classified in spectrum. So gonococci, pneumococci, staphylococcus aureus, meningococci, E. coli, Shigella, and some streptomyces pyogenes, streptomyces viridans, and anaerobes. Okay, and resistance, how it occurs. See, it is very, very small, written in small letter, but let me read it out for your sake. So here, if a bacteria produce increased amount of PABA, even though PABA, conversion of PABA to tetrahydrofolic acid is blocked, but if a bacteria produces abnormal amounts of PABA, okay, see here you are using a particular dose of an sulfonamide to block the effect of PABA. But if the PABA production is very abnormal, your dose may not be sufficient to block the entire conversion of PABA to tetrahydrofolic acid. That's why if any bacteria, when it gains resistance, one of the mechanism of gaining resistance is bacteria producing abnormal amount of para-amino-benzoic acid. Okay, when it produces more amount of para-amino-benzoic acid, then even though some part of PABA conversion to THFA is blocked by sulfonamides by inhibiting the enzyme folate synthetase, but rest of the PABA will be active, and it starts converting PABA to tetrahydrofolic acid. So that is one way. And here, another thing is their folate synthetase has low affinity to sulfonamide. This is also another mechanism. See, what bacteria will do when it is exposed to when it is exposed to sulfonamide continuously for many months, folate synthetase initially it will be inhibited, and conversion of PABA to tetrahydrofolic acid will be blocked. But a bacteria, it alters the structure of folate synthetase. It alters the structure of folate synthetase. For example, if it alters its binding site, a new folate synthetase will be produced by the bacteria, which will have an altered binding site and which will not allow the sulfonamides to get attached. Then even if you use high doses of sulfonamide, that will fail to bind with folate synthetase, and this conversion from PABA to tetrahydrofolic acid will continue, and the bacteria becomes very, very effective. Okay, so these are the two major uh, mechanisms how sulfonamides develop resistance to how bacteria develops resistance to sulfonamides. Okay, so one is bacteria will produce increased amount of PABA, so that more PABA can be converted into tetrahydrofolic acid, so that tetrahydrofolic acid will be formed. Even though you take sulfonamide, if PABA is more, it will form more, it will convert into more tetrahydrofolic acid, and bacterial multiplication will continue. Bacteria remains unaffected. And another one is alteration in the folate synthetase. So bacteria will change the structure of folate synthetase. It will change the binding site, so that sulfonamides fails to bind with folate synthetase, and finally uh, it fails to inhibit the formation of tetrahydrofolic acid. So these are the two mechanisms. Okay. And coming to pharmacokinetics, please try to understand. Pharmacokinetics, sulfonamides are rapidly and nearly completely absorbed from GIT. Their absorption is good. Plasma protein binding differs considerably. So 10 to 95%. I will write somewhere here PPB, plasma protein binding, that is 10 to 95%. See how there is a variation in protein binding side. Some drugs will bind 10% and 90% will be free. They will excrete it faster. They become short acting. Okay. Some drugs will bind 95%, means only 5% will be free. After excretion of 5%, so slowly the protein will release the drug, and slowly 5% will be released, and that makes the duration of action longer. Okay. That's why you can see here, highly protein bound drugs, they are long acting. They are long acting. Okay. And they cross placenta freely. Please try to understand. They are very dangerous. They can cross placenta. Okay. And primary metabolic pathway of these sulfonamides are acetylation. Okay. So acetylation at N4. So I think I have shown you this one. So here, this N4 nitrogen is acetylated. Acetylation occurs to the para nitrogen present at para amino position. So that will be the metabolic pathway by non-microsomal enzyme, that is acetyl transferases. That is phase 2 metabolism. Acetyl transferases. Okay. So now the acetylated derivative, here there is a problem. So please try to understand. Here what happens, the acetylated derivative, when sulfonamides undergo metabolism by acetylation or acetyl transferase, it is converted into an acetylated derivative, and that acetylated derivative contributes to many side effects. Okay, because when that acetylated derivative, it is less soluble in acidic urine. Please try to understand. It is less soluble in acidic urine than the parent drug. If your kidney environment is acidic, if your kidney environment is acidic, then it fails to enter into the nephron because of its less solubility. Solubility will be less. Okay. Some amount will enter into the kidney, and in kidney they form crystals. They form crystals in the kidney because of less solubility. And remaining most of the sulfonamides, which has to be excreted, they stay in the blood and they will increase the toxicity. Okay. Is it clear? So that is the problem. So what I am saying, I will repeat. So sulfonamides, their primary pathway of metabolism is acetylation at N4 position by an enzyme, acetyl transferase, and that after acetylation, whatever the excretory product which has to be excreted, that is formed, that is inactive, and that contributes to adverse effects. And that when they enter into the kidney, if the environment of the kidney is acidic, then they form crystals. They form crystals, and that will I mean to say that that is very dangerous, and you will have crystals in the urine. You will have crystals in the urine, and that is called as crystalluria. That is called as crystalluria, and there will be a severe pain and burning sensation during urination. Okay, so because of formation of crystals, the drug which is metabolized by acetylation, its acetylated derivative is less soluble in acidic urine. It is less soluble in acidic urine. That's why you have to take large amount of fluids while taking sulfonamides. You have to take large amount of fluids, so that you have to make your environment of the kidney basic. You have to increase the pH. If the pH is increased, then that crystalline product of the drug which has to be excreted, it will be solubilized and it will smoothly go out of your urine. Okay, so that is what we call it as crystalluria. Okay, I will repeat why there is crystalluria with sulfonamides, because when sulfonamides enters into the kidney, if that as an acylated product, and that acylated derivative, when it enters into the kidney for excretion, if the urine is acidic, it does not get solubilized, it is less soluble, and that will result in the formation of crystals, and that is called as crystalluria. Okay, and sometimes this acylated form, it will even deposit in the blood, accumulate in the blood with renal failure. Okay, that so if that acylated product, some amount it will enter into the kidney, some amount it stays in the blood, and that may even cause blood, especially in renal failure patients, definitely it can even leads to toxicity. Okay, so that is the problem with sulfonamides. Okay, please remember, in exams, competitive exams, this is one of the guarantee question. Crystalluria is seen with which antibiotic? Penicillin, tetracycline, some aminoglycosides, and sulfonamides. Your answer should be sulfonamides. Okay. And lastly, let me quote some adverse effects here. So I will end the discussion by completing these adverse effects. You can see here nausea, vomiting, and epigastric pain. Just above your stomach, there is a pain. Okay, like how we see in ulcer. So crystalluria is one of the major problem what I discussed, due to less solubility of the drugs in your acidic urine, that is acylated derivative, and this can be minimized by taking plenty of fluid. Plenty of fluids can be taken, drink large amount of water, and by alkalinizing the urine. Urine can be alkalinized by using a diuretic. You can take a diuretic, and that can be sodium bicarbonate. Large amount of sodium bicarbonate has to be given to the patient, so that the urine becomes alkaline, and that in the alkaline environment, the drug will be more soluble, and that can be easily excreted out. Okay. And here you can see hypersensitivity, some allergic reactions can occur, rashes, urticaria. Urticaria is nothing but it is elevated patches. You will have swelling, you will have a patch which is swollen, and that patch will be red in color followed by itching. So urticaria means patch which is elevated and which is red in color and which produces itching. Elevated patch, red color, and itching. That is called urticaria. And here you can also see Stevens-Johnson's syndrome. You can please zoom it a bit. Stevens-Johnson syndrome. Stevens-Johnson syndrome, it is also a type of hypersensitivity. So where there is a painful red or purplish patch. There is a painful red or purplish patch that spreads blisters on the skin. I think blisters, you know that. Blisters means fluid filled cavities. Whenever hot water falls, a drop of very hot water falls on your skin, you will have a blister, a small bump which is filled with fluid. So that is what we call it as blister. Such kind of blisters can be seen which are red in color, which are associated with itching. So that is what we call it as Stevens-Johnson syndrome. In Stevens-Johnson syndrome, you will have a painful red or purplish rash, which is red in color or purple in color, and that spread as blister, that will further convert into blister. Okay. And another one here you can see exfoliative dermatitis. This is also one of the problems. Exfoliative dermatitis means here there is a rash and you have scaling. Okay, scaling means your skin can be peeled out. I think nowadays you have this what is that peel off creams will be there. Okay, I think when you apply on your face, after some 20 minutes or half an hour, you can just remove the layer. You can peel it out. Okay, it will remove your dust, moisture, and all. Okay, that is what, like how that particular cream, when applied on the skin, which can be peeled off, in the same manner, your skin will be peeled off. It will come out. It will come out. Like how a snake is going to shed the skin, in the same manner, your skin will become very, very sensitive and it can be removed easily. Okay, layers of the skin can be removed, will come out, will peel. Like how orange will be peeled. In the same manner, skin can also be peeled. So that is what we call it as exfoliative dermatitis. Okay, and along with that you have drug fever. Drug fever means your body temperature increases, especially to a particular antibiotic. Whenever you take that antibiotic, your body temperature will suddenly increase. Okay, and whenever your sulfonamide is not available in your blood, your body temperature will be normal. That is febrile reaction to a therapeutic agent. When in the presence of drug, your body temperature will increase. Okay, and photosensitization, sensitivity to the light, is also reported. Means whenever you are exposed to sunlight, you will have eye burns, you will have rashes, burning of the skin. So that is also reported. Okay, and hepatitis is one of the problem. Okay, and here you can see topical use of sulfonamide, risk of contact sensitization, liver damage, contact sensitization. When you touch any substance, immediately your skin becomes very allergic to certain substances. Okay, so even if you I mean to say that if you hold certain objects, your skin becomes very very insensitive and your skin starts damaging. Okay, the same object will be held by many individuals. For example, if you are doing a practical in a lab, okay, so most of you are using test tubes. Okay, suppose 8 to 10 members are using the test tube. That out of 8 to 10 members, 7 members does not have any problem with when they hold test tube, but 8th member who is using sulfonamide, that particular person, whenever he touches the test tube or any object, immediately there is a rashes or inflammation of the skin. So that kind of I can say that risk of contact sensitization can also be seen when sulfonamides are used topically. When you apply silver sulfadiazine on the skin, okay, or when you use mefenide on the skin, or when you use I mean to say that especially what is that sulfostamide sodium as eye drops, definitely they will cause contact sensitization. And even you have hemolysis, breakdown of RBC. Okay, and there is another problem which is called as kernicterus. Okay, kernicterus is a problem which is seen especially in newborn. The problem is, let me tell you, you know that one of the bile pigment is bilirubin, which is very very essential for the emulsification of fat. Okay, so bile pigment bilirubin is produced by your liver, which is stored in the gallbladder and which is released in the small intestine, and which is responsible for emulsification of your fat, that is digestion. So whenever bilirubin enters into the blood, it will bind with some proteins, albumin. I will write it as B bilirubin, and I will write it as A. Generally in blood, bilirubin will be found attached with albumin. Okay, so free bilirubin will be there and combined bilirubin will be there. Okay, and there is a ratio actually. Okay, only free bilirubin can go for can cause can involve in digestion. Okay, and as the free bilirubin concentration becomes low, this combined bilirubin, this albumin which is holding the bilirubin, it will leave the bilirubin, and once again the bilirubin concentration increases and further digestion process will continue. Okay, but here the problem is, let me tell you, when you use sulfonamides, what sulfonamides will do, sulfonamides will prevent the binding of bilirubin to albumin. Sulfonamides will prevent the binding of bilirubin in the blood to albumin. You can see here. So displacement of bilirubin from the protein binding sites means whatever the bilirubin, whatever the site on the albumin with which bilirubin used to bind, sulfonamides will interfere and sulfonamides will bind with albumin instead of bilirubin, making the bilirubin more free. Okay, sulfonamides prevents the binding of bilirubin to albumin in the blood. Instead, it will bind and it will make the bilirubin free. Okay, so you may ask the question, sir, what happens if bilirubin becomes free? Let it become free. Okay, in adults, please try to understand. In adults, if bilirubin concentration increases, if free bilirubin levels will increase due to sulfonamides, which is going to prevent bilirubin in binding with albumin. So free bilirubin concentration will increase, and you know that when free bilirubin concentration increases, it's deposit, it gets deposited in your skin, in your nails, and in your mucous membrane, and that will result as hyperbilirubinemia, or what we call it as jaundice maker in adults. But in neonates, the problem is their blood-brain barrier is not fully matured. Please try to understand. In adults, bilirubin will not enter into the brain because our blood-brain barrier is very strong. It will not permit the entry of bilirubin into the brain. But in newborn infants, when sulfonamides will not allow the bilirubin to bind with albumin, when sulfonamides will make the bilirubin free, more free bilirubin will increase, and that free bilirubin in adults, it will not enter into the brain because our blood-brain barrier is fully matured. Okay, that's why we have jaundice. But in neonates, what happens, as their blood-brain barrier is not fully matured, bilirubin can enter into the brain, and that will cause brain damage. That will cause brain damage, severe damage to the cranial nerves of the brain. Many nerves in the brain will damage, and that will result in the child will enter into epilepsy, coma, and death. Okay, that particular problem is called as kernicterus. That is called as kernicterus. Okay, so displacement of bilirubin from its protein binding site by sulfonamides, making the free, making or increasing the concentration of free bilirubin in the blood, and that free bilirubin in neonate will enter into the blood-brain barrier, and that will cause neural symptom, and that will cause brain damage. So that is what we call it as kernicterus. That's why while using sulfonamides in neonates, you should be very, very careful. Okay, try to avoid usage of sulfonamides in neonates, because this is the problem. Okay, so it will make the bilirubin free. It will not allow the bilirubin to attach with albumin. It will interfere with protein, plasma protein binding of bilirubin with albumin, and that will result in increase in concentration of free bilirubin, and that will enter into the brain in neonate, and that will cause a serious problem. Okay, so that's it. So that is about adverse reactions of sulfonamides. Coming to therapeutic uses, let me just quote it out. It is used in urinary tract infection. It is used in streptococcal pharyngitis and gum infections. It is also used in many eye infections, that is trachoma and inclusion conjunctivitis. Okay, in newborn. It is used in lymphogranuloma venerum, that is a sexually transmitted disease. It can be also used, it is also effective in malaria. It is also effective in toxoplasmosis, which is a parasite or protozoa. Okay, that is called Toxoplasma gondii. Okay, it is a protozoal infection which is caused by Toxoplasma gondii, and it is going to affect eyes, brain, liver, and lungs. Such a dangerous infection. And as I told you, it is also used in burns, and it is also used on nocardiosis. Okay, a tuberculosis-like infection, but it is not a TB infection. The symptoms may be similar to TB, but it is not a TB infection. Okay, so these are all the therapeutic uses of sulfonamides. Okay, so I will stop now. So I will display the video. You please watch the video, and if you have any doubts, please share with me, and I would like to have an interaction, and I will definitely solve your doubts. Thank you. Thank you very much.